You're going to be doing a lot of hospital discharges over your years of training, so we'll hit a few highlights for you. Okay, so the things that I wish to talk about today, we're going to go over why the discharge process is on the risky side for our patients. We don't always talk about it, but how do you tell if someone is appropriate for discharge, and if so, to where? There are elements of the discharge process, and we're going to talk about each of those individually. Then I'm going to pause and see if you all have any questions, and then we'll stop the recording, and we'll have a few tips at the end, which we should still have plenty of time for those, for some Cerner suggestions. Sorry, VA, at the moment, I know you don't have Cerner yet, but I hear rumors to the effect that it's in the VA's future, so you might be interested in some of the shortcuts eventually. So, okay. So one of the things that we do know over time as we have taken our patients to where we have sicker and sicker patients in the hospital, so fewer patients are being discharged from the hospital straight to home. Still is by far the majority, well over 3/4 of them are still ready to go from the hospital to home, sometimes with some help, but it's had dropped like 10% from the 10 years earlier. So the direction is for sicker people often needing to go somewhere besides home. We have about 10% going to long-term, subacute rehab, that sort of stuff. Of those who do go home, many of them, here you see 6.5%, need some type of home health, be it PT, nursing, what have you. Our numbers may be a little bit higher than this. They have about 1% leave against medical advice, but nevertheless, that is one of the options for how to leave the hospital. Approximately 2.5% leave the hospital via the morgue. A very small percentage of our patients, but some actually will leave to what's called another short-term hospital, acute care hospital, perhaps by patient wishes, or we don't have services that are offered, and we'll go over some of the impact there. So what happens when we discharge a patient, particularly from our general medical type of wards? We know a lot more about the Medicare age population, and of course, being over 65 as a general rule, you know they're going to be a little bit riskier population anyway. About 1 in 5, or 20% of those patients, are readmitted within 30 days of discharge. Now, at the moment, you may or may not know, there are a handful of diagnoses, especially that we in medicine are stuck with. If a patient is readmitted within 30 days, for a COPD exacerbation, for a heart failure exacerbation, or post-myocardial infarction, that's counted against the hospital. You can come in with a heart failure exacerbation, we discharge you, and a week later you get hit by a truck and are readmitted. Doesn't matter that it's not readmission for the same diagnosis. Those are counted up, and the way Medicare acts now for those things, the hospital has a reduction in the amount of money they're paid for all Medicare patients, regardless of reason. So you could be in with a hip fracture, the sum total. So it's important to the hospital, but it's also important from our point of view is, have we messed up somehow, something we've done maybe that made that patient more likely to bounce back within 30 days? We do know there is some evidence that this is not a really good marker for the quality of care that patients receive that bounce back. It could have to do with the severity of their illness. We know there are some that have comorbidities. Sometimes they still are recreational cocaine users and things like that might bounce back with their heart failure or another MI. But it's important for you to realize that there are consequences that may be more global than just to that one particular patient. So when you hear people talk about the 30-day readmission rates, that's one of the reasons why. So when 20% of Medicare patients are in this category that are readmitted within 30 days, somebody's paying attention to that. from our point of view, a really important piece of information is that 2/3 of those are related to adverse drug events. And we are the kings and queens of prescribing medications, right? So we need to be aware of that. In our discipline, less of them are coming back because of procedures, but you can see that 70% of the readmission rates are related to a previous procedure. Okay. So these bounce back cases, for whatever reason, there is actually a high association with ongoing disability. 1/3 of them will lead potentially to, say, permanent nursing home placement. So we want to be aware of the riskiness and anything we can do, because 2/3 of these events are preventable or at least modifiable so that they would have potentially had a less severity. Okay. Another important reason that discharge time frame is a little bit risky for patients is we don't always have all of the data back when we send a patient home from the hospital. In one study, they found that about 40% of their patients had either pending blood work or lab tests that had been obtained but not resulted when the patient had left the hospital. And of that, 10% of them required some type of intervention based on those results that maybe nobody ever looked at. Importantly, the docs or providers that are seeing those patients in follow-up, 2/3 of them were unaware that there was something still pending when their patient left the hospital. So risky time period. Sadly, adverse events occur more frequently in teaching hospitals than in large or small community hospitals. And some of that has to do with the complexity of patients that we tend to have, but we also have a lot of people involved in the care, multiple members of the team, multiple teams. We would like to be better than small or large community hospitals. So one of the ways to tackle that is, first, we need to be aware. Okay, so until the not too recent past, not too distant past, anyway, discharges, the focus on safety and discharges is a relatively recent phenomenon. So it's been tackled here in the last decade, and factors that may improve the safety have been identified, and we're going to try to emphasize the ones that we know a little bit about. I will tell you there is little good solid evidence that any one factor improves the overall safety of your discharges and your readmission rates. A bunch of the things that I am going to talk about in a multifactorial, if multiple things are done, there is some evidence, still not overwhelming evidence, but some evidence that you can improve safety and readmission. So we're going to talk about that. But regardless, we would like to do a high level of care, so we will hit some of those. Discharges can be very unplanned. You know, have an opportunity, a moment, and you get somebody out the door quickly, and maybe we haven't had time to educate or assess or make sure of all of the things we will be talking about. That makes discharges risky. We are now in a hospitalist and a ambulatory world. The same doctor is not taking care of that patient from the get-go and then seeing them in follow-up. Not only that, we are in a world where this week it's this hospitalist and they came in, and then they've handed it off to this hospitalist and they've been in the intensive care unit, and these specialists have seen the patient. So there is a lot of working parts in terms of different providers interacting. So who's wrapping their arms around the whole picture? So that's an opportunity for glitches. And because of the multiplicity of providers, the communication can break down between us, but it also can break down between patients. And one of the things you will hear if you're in the hospitalist world is, what was the patient satisfaction survey, that sort of stuff. One of the things in a teaching hospital like this that we get dinged on frequently is physician-to-patient communication, and that is often because one team or part of the team will tell a patient, one thing and somebody else comes in and tells them something completely differently, we confuse the patient. So that's important. Okay. And lastly on this slide, less than half of patients discharged from an academic general medicine service know their diagnosis, why they were even in the hospital. They don't know their treatment plan or the side effects. So there's a lot of opportunities. So kind of in summary, hospital discharges are complex. We often have unintended readmissions that can occur, especially when the patient follow-up is unclear and without defined roles in terms of who's doing what. We may not pay very much attention to the patient's understanding or their caregiver's understanding and their ability, not just their understanding, but their ability when the patient leaves us. We mentioned the fragmented care that can contribute to this complexity, and ultimately we need to be thinking of a patient-centered approach to their medication use and access and treatment options. So kind of background. So what are the elements of the discharge process? I've got 6 items listed here, and we'll go over each of them. Discharge planning, medication reconciliation, the discharge summary itself, patient education instructions, what happens post-discharge from the hospitalist perspective, and then lastly I'll go over a discharge checklist on that. All right. One of the things you need to think about is discharge planning starts almost immediately after they hit the door. I like to tell my teams, you tackle the ABCDs: airway, breathing, circulation, disposition. So when A, B, and C are stable, you need to be thinking about disposition right away. Right away. That could be even, is this patient going to be placed in observation, or is this patient going to be placed inpatient? Because if you think your best guess is this person needs to go to a rehab facility at discharge, you're going to prefer to put them as an inpatient. So it starts right from the beginning. It starts as part of your history and physical, which can include their social support network, their living conditions, their medication plan. You'll hear this over and over again. What meds are they on? Are they taking them? Are they able to get them? So from the beginning, you're finding out all that information. As we learn, we don't wait till the last day. As we learn what we are diagnosing them with, we need to be teaching the patient every day. And as we evolve, we'll ultimately get to discharge instructions and an actual discharge event related to when you write your discharge order. And then there are some post-discharge follow-up that we'll hit on, okay? Okay. So you've got somebody you think is about ready to be discharged. You need to be aware of ultimately where you think they're going to be ready to go home or ready to be discharged to. So part of that decision making is, what is their cognitive status? What is their current activity level and functional status? What's their home like? Do they have stairs they have to get into but they can't do anything but go in a wheelchair right now? Do they have any support? It may not be family, but sometimes close friends, neighbors, what have you, are willing to help out. Do they have nobody? Are they homeless? All of those factors will play into whether a patient is appropriate for discharge, because they have to have a safe place for us to discharge them. Can they obtain their medications and services? Do they have transportation not only from the hospital but to any follow-up treatment or appointments that you have lined up for them? And if they need it, is there any community assistance available that they could access that might allow you to discharge the patient? So if you think a patient's going to be discharged home, they need to be able to obtain their medication and administer their own medication, or have a caregiver support person that can do that for them. Can they do their own self-care activities or have someone able and willing to do that for them? Are they able to eat an appropriate diet? Oh, we just took out their Dobhoff tube, you know, they have nothing else. We haven't assessed their speech, their swallowing, that sort of stuff. So are they able to maintain adequate hydration and nutrition? And can we help arrange follow-up with appropriate providers, and can they get there? So that's somebody that they meet all that criteria, it's appropriate to discharge them home. There are inpatient rehab facilities, and here in town, obviously, Fraser is our acute care inpatient rehab facility. To be eligible to go to that, they have to typically be able to participate in at least 3 hours of therapy per day. And at those facilities, typically they are supervised by a physician at least 3 times a week. All right. Long-term acute care hospitals, sometimes our patients out of the ICU might meet criteria for that. Usually, if that's the case, if somebody anticipates going to need long-term support, it's best to get that consideration done while they're still in the ICU. For example, a long-term acute care hospital can manage someone who's chronically on a ventilator, needs prolonged IV therapy, needs daily monitoring. So there's some criteria for that. If they get too well, they're not eligible for a long-term acute care hospital. They usually anticipate those folks are going to be in that facility at least 25 days. Okay. What we're more experienced with is folks that who are not eligible to go home. We try to get them into a subacute rehab. And at least for our Medicare eligible or Medicare insured patients, they have to spend that 3 midnight rule, that 72 hours. It's actually not 72 hours, it's actually 3 midnights to qualify for their insurance to pay for their subacute rehab. They have to have some skilled need, be it physical therapy, occupational speech therapy, or skilled nursing of some kind, that of at least an hour a day to qualify. So if they're too good, their insurance company won't pay for that. And it's very hard to get somebody straight from the hospital to long-term nursing home. The nursing homes are also affiliated with the subacute rehab, but for their financial reasons, they want to get the benefit of the higher reimbursement, at least of a subacute rehab stay, before they are converted into a long-term patient. So we don't always know that, but that's their thinking on that. So sometimes we'll get resistance if they are, again, not needing any skill. Okay? All right. We've already talked about the risks of medications. Medication reconciliation should start right away. For one reason, it gets those annoying pop-ups that come over and over again when you click on a patient and you haven't done their admission reconciliation. The sooner you do that, the sooner that goes away. It's important for ongoing inpatient care, so we know we're not missing anything. But it also makes, ultimately, our discharge medication reconciliation easier. The good thing here is we do have ancillary support. There are folks down in the ER, pharmacy techs that will begin that, and nurses that will begin that process for us, but it isn't always complete. Many times on our ward teams, etc., you will have a pharmacist or pharmacy student or pharmacy resident who will contact pharmacies for you to get appropriate doses and that sort of thing. So get it done as soon as possible. As I said, it actually helps with current care, but it also makes discharging easier. Okay. One of the things that we often don't think about, but is important as you're anticipating discharge, is a couple of things. Is, can the patient afford them if you prescribe them? Maybe they keep bouncing back because nobody's asked them why they're not taking their medication, and it might be the copay is too high. They might be insured, but the copay is that still it's $100 a month even with my copay. Can they understand how to take whatever? Are they using their inhaler, for example, properly? And then, of course, as part of the ultimate discharge reconciliation, we do a lot of clicking and it imports. We need to highlight, especially for patients, medications that were stopped or medications that were continued but at a different dose range. I think it's easier sometimes to pay attention to the new medications added because they'll have a new prescription or what have you. But in our documentations, that's something that If we highlight, I've had patients that they've been taking 2 of the same medicines, they come back in, I've been taking lisinopril and something else, I picked one that was, I've used the generic so long I've forgotten the brand name, but anyway, they're taking 2 of the same medication and they may have consequences because they couldn't tell it was any different. So, and if they're getting their medications filled at multiple pharmacies, that may not be picked up by one of our safety net opportunities, which is other team members. Okay. And just as a real quick, if you're in the admit management and the medications here, you can see that, and all of these that are highlighted in orange have not been reconciled yet. And it even tells you here you have 9 unreconciled. So the sooner it's done, the better. Okay. So we've talked about, are they appropriate for discharge, and starting to plan that, and their medication reconciliation. Before we ultimately let them leave, we need to be thinking about our discharge summary. You're supposed to complete your discharge summary here at Yeovil within 48 hours, right? Isn't that what they tell you? 48 hours? Yes, no, maybe? Okay. These are Joint Commission standards for your discharge summary, and I will tell you this is kind of a bare minimum. Why were they in the hospital? Significant findings? Did they have any procedures, specific treatments that we provided while they were here? What condition were they when we discharged them? Any patient and family instructions, and most importantly, not the attending signature. So that's kind of a bare minimum. But remember, the discharge summary, for one thing, is our primary way we communicate with the aftercare providers, the PCP, what have you. So if we don't do it in a timely fashion, they don't get it. They don't know what to expect. We are very lucky here at University Hospital. We have nurse clinicians on our medical ward teams, and they will bend over backwards to help make sure that this communication is done in a timely fashion. But I can tell you, they frequently are bothered because they've made a timely follow-up for the patient, and we don't, and they will send that completed discharge summary to the follow-up providers, and if we haven't finished it, not so good. So it has an important impact. It's easier than it ever has been before now that we're electronic records. Back when you had to dictate, it took forever. But it is important from a safety point of view to get those done as soon as possible, and absolutely before the patient is seen in follow-up, so they could receive the information that is very important that you're going to share with them. Okay. And I've already mentioned the patients often don't know what they're on, their follow-up, etc. Okay. Again, you're lucky with our nurse clinicians. They do this part, but if you are at a place where you don't have one and you're in charge of scheduling your own follow-up appointments for your patients, it's important to ask them, is there a time of the week, time of the day they can or cannot show up? If you make them on a morning appointment and they can't get there because their ride's only available in the afternoon, there'll be a no-show. So our nurse clinicians ask, do they have a ride to get to these appointments? And they actually make these appointments for us, and save yourself a little reminder for those patients discharged over the weekend, and they will do it for you Monday. The pending lab tests and other tests, part of our job is to make sure that we don't miss them. I don't talk about medical legal very often, but one of the things that we all need to know is if we ordered it, we are responsible no matter really who we say. So there is a way of doing a communication message to yourself to say, follow up on Mrs. Jones, ANA, or whatever, if it's a send-out lab. And you keep that reminder until you've checked it off of your list. You can say you're going to defer it to the PCP to follow up. I'm not going to trust that the lawyer is going to accept that handoff if we ordered the test and it's an important test. So pay attention to that as part of the process. Take ownership of it. If it was important enough for us to order, we should follow up on it. Okay. So a little bit more than what the Joint Commission requires. This is a lot of what we ask you to do in our discharge summaries. Obviously, you have to have the admitting diagnosis or the, quote, problem that led to hospitalization. You have to have a principal final diagnosis. And as an aside, like for your coders, sometimes we don't know, and they have a couple of things. A classic one is, say, you've got somebody who's come in, they're short of breath, they have COPD, they have congestive heart failure, and they have some symptoms of both of those, and you treat both of those, all right? I don't know which one of those pays the hospital more. I don't need to decide that. I can say as my principal final diagnosis, acute left systolic heart failure exacerbation with acute COPD exacerbation with acute on chronic hypoxic respiratory failure. They can pick whichever one pays the most to the hospital. They can pick whichever one is the major comorbidity. Because a lot of times, you know, people try to just pick one diagnosis. You don't have to. Anything else you can list under secondary diagnoses if they are things that we treated and managed in the hospital. You don't have to list all their chronic medical problems there. We do want to talk about their key findings and test results. A pet peeve of mine is when you cut and paste the full radiology reports and leave them in there. The more you have in your summary, the less someone's going to process. So copy and paste, that's fine, but delete everything that is not important. Sometimes the important stuff is in the body, not just the summary. You know that better than whoever's going to receive that patient. So make them short, make them brief, make it a summary. Don't make it a complete copy of their whole time they were in the hospital. Brief hospital course. Especially for patients that have been in the hospital for a while, it is much more effective to do this in a problem-focused fashion. Don't do it this happened and then that happened. If you do it problem-focused, you can do it in a much more succinct fashion. All right. You must have the condition at discharge included, and that has a bunch of things like diet and activity, weight bearing or driving limitations, that sort of thing. Where are they being discharged to? They're going home, they're going to a facility. I've put in red because it's very important. Medications at discharge. You can import some of that, but again, I want you to be in charge of highlighting things that are different from when they came into the hospital. Okay. Your document's going to include any follow-up plans. It may include, because sometimes we do follow-up testing. You got an echocardiogram ordered in a week before your follow-up appointment, so that should be listed there. Any anticipated problems, you know, that's a lot of times is in their instructions. If you get fever, if you get chest pain, if whatever, put that in there. Sometimes we give suggestions to the follow-up provider in terms of what we expect, what we've done. They might need more tweaking of their diuretics or more potassium, but whatever. If you have some suggestions to the provider who will be seeing the patient at the first follow-up visit, list them in there. Again, in red, anything that's pending. If your subspecialist, your consultants had any specific recommendations, include those. We're supposed to document patient education, and I think that often happens under the nursing component. I will tell you, we don't yet have what I would consider an optimal patient education, a patient discharge education packet handout. If you look at them, they include a lot of extraneous stuff. Being a stroke center, I don't know if you've noticed, all of our discharge packets have signs and symptoms of stroke, even though that may not be relevant, and it may actually detract our patients paying attention to the things that we want them to pay attention to that are related to why they came in the hospital. So ultimately, going forward, it'd be awesome if we can get a more patient-centered discharge education packet than we currently have. The numbers are on there, who to call, etc. And then lastly, copy to whichever providers need to receive a copy, definitely the primary care, any subspecialists, etc., that will be seeing the patient in follow-up. How do we know if our patient knows what's going on with their whole illness and their management? There are a variety of tools that have been developed, and we'll talk about some of them. We'll talk about our actual job of teaching the patient. There's a technique to teach back. The upper levels have definitely been exposed to this. I don't know if the interns have encountered that. It often happens with Dr. Kubiak in the clinic where you get some training on teach back. It's not just can they regurgitate facts, do they actually comprehend what's going on? And then there's an Ask Me 3 thing that will help assess some of this. So teaching the patient. Do they know why they were admitted to the hospital? Do they know their limitations, their current condition when we're ready to send them out? Do they have any clue as to what their current medications are? So when we add new medications, we don't have to wait till the day of discharge to begin teaching about this medication, lisinopril, that causes, it's for your blood pressure, it's for your heart failure. Do let your doctor know if you start getting a cough that you haven't previously had on that medication, as an example. There are a variety of ways we can do the teach-back methods that incorporate the patient's health literacy, language and culture issues that may impede or block their understanding. It could be how we talk. We might be doing too much medical jargon, so be aware of that. So, first, what is teach back? So teach back, show me methods, show me as if it's actually something mechanical, like say an inhaler use, for example. So you start, the health system providers were giving a new concept, either new health information, change in management, what have you. So the clinician goes in and explains or demonstrates. Then the next step is the clinician assesses the patient's recall and their comprehension, and where appropriate, we ask the patient to demonstrate. Can you give yourself that insulin shot, for example? You see what they've said back to you, you tweak it, clarify it, and then you reassess. And hopefully you get to a point where you're not going around this loop but one time, but you go through it until you realize that this method is not going to work, and then you get a backup plan. But this is very effective for many people, and it picks up things that you may not have appreciated what's going on. And then, as I said, if we do this, we actually can, it's been shown you can get improved adherence to medication use, follow-up, etc., proper techniques. So as part of the teach-back, one of the things that we as the providers need to do is we take the onus on ourselves that if they don't understand, it's our fault. We didn't explain properly. So I want to make sure I didn't leave anything out that I should have told you. So can you tell me, let me know what to do so that I'll be sure I know what's important, okay? So just kind of ask them to reflect back what they have heard you say. I want to be sure I did a good job explaining your blood pressure medications, because this can be confusing. Can you tell me what changes we decided to make and how you're going to take your medications down going forward with the changes we've made? Another way is how are they going to communicate this to someone else in the family? So when you go home and your grandchild asks you what the doctor said about your heart, how are you going to explain it to your grandchild? So the different ways of phrasing it, all the while your goal is to see, have you done a job, effective job communicating with the patient what's actually going on with them and how to manage it. Okay. So one of the things, the patient actually may know quite well and reflect back quite well what you have said, and we often stop there. Okay? You need to take your insulin twice a day. I want you to check your blood sugars 4 times a day, and I want you to bring that blood sugar log in with you when you go see your doctor. Okay? Do you see yourself able to follow those instructions? Nope, I'm afraid of needles. I'm not going to do it. You know, you just may not have even thought about asking that question, but they have a very strong opinion about their answer to that, and we skip this. No, I don't think I can do that because I don't have transportation. I'm not going to be able to make that follow-up appointment. So they want to please you, so they may not volunteer that information. So we need to know their willingness and ability to do some of the things that we're trying to make happen, because otherwise it doesn't, and they may be bouncing back within that 30-day time window. So They may have functional barriers, could be a memory problem, environmental barriers, and they may have attitudinal barriers. Not everybody trusts doctors, and sometimes that's for good reason. So we just need to be aware of that, because we do them no good if we're at loggerheads. You know, we're saying one thing and they're hearing something entirely differently, or just not interested in what we have to offer. And then you kind of explore what the next steps are. Is what do you want out of the health system? You know, if you're not willing to follow our recommendations, you know, do you have an alternative? So, okay. Ask me 3. All of our patients should be able to do this. What's my main problem? What do I need to do to manage that main problem? What happens if I don't manage that thing that's important? Okay. You're up all night urinating if you don't take your insulin. Okay. Just, you can make it as relevant to them. It increases your risk of foot amputation. They may not care about that, but they might care about nocturia. So make it relevant. You know, it increases your risk of death. It may not be important to them. Okay. Post-discharge activities. Again, you are lucky here because your nurse clinicians do a lot of this for you, and that is like making sure that the discharge summary gets sent in a timely fashion to the post-care follow-up providers. It is, as you can see here, the discharge summary reaches the PCP by the first follow-up visit in only 12 to 34% of their follow-up visits. There's some suggestion, particularly in the Medicare population, that if they are seen within the first week after discharge, they are less likely to be readmitted. It's not good and solid, but some suggestion that it's beneficial. It isn't going to be beneficial if the PCP doesn't have the information about the hospitalization, because they won't know. And sometimes they'll just turn right around and readmit the patient to you. Okay, so that actually can be counterproductive. You're trying to keep them out of the hospital. You've sent them for follow-up, and they, go back to the hospital. You have edema or whatever. So, okay. We do this actually before. Have they gotten all their services, home health lined up, any durable medical equipment that they need? Follow-up. Our nurse clinicians call our patients 48 to 72 hours after discharge, depending on where they are, weekend and that kind of stuff, to see if they've had any problems filling their medications or any other issues or any confusion. That may or may not help reduce readmissions. It doesn't hurt it. It might help it. We know that much. Okay. So there are these redesigned, re-engineered discharge checklists, much more detailed than just the Joint Commission. We've gone over all of these pretty much. The medicine reconciliation, the discharge plan should include those things we highlighted. We need to have their follow-up appointments lined up. Any outstanding pending lab tests and radiology needs to be dealt with in terms of who's going to take ownership of following up for those things. Do they have any therapy, home health, outpatient physical therapy, outpatient antibiotic, anything like that? Have we arranged that appropriately? Does the patient have a written discharge plan? Ideally one that is at their educational level that they can understand in their language where appropriate. What is the patient to do? Should they have any problems that develop? Who's going to answer those questions for them? Have we educated them? Have we assessed their understanding? Have we assessed their willingness to participate in those activities that we think that they are going to be doing? Have we finished our discharge summary in 48 hours and made sure it was sent in a timely fashion to the outpatient follow-up providers? Got our post-discharge phone call lined up. So I think the most important thing for us to remember about the whole discharge process, it's my favorite part of medical care, right? You're excited when you get to discharge somebody. Actually, it's not. You like to take care of neat people with fun diagnoses, but it's important. It's a very risky time for our patients. Common things happen, medication problems, failure to follow up labs, failure to communicate with their follow-up providers. We have an opportunity with our patients to do the best we can, and by recognizing that this is just as important as getting that stat echocardiogram or getting antibiotics on board in terms of the patient's ultimate well-being. We need to do a good job. We need to communicate effectively and do our best to avoid preventable complications that lead to people coming back sometimes with then ongoing disabilities related to whatever we may have not done optimally when we discharged them.